Welcome back to the Pro PA podcast. I'm your host, Prof G, and this is another episode of the MSK101 series, where we break down high-yield rheumatologic and musculoskeletal topics from the PANCE blueprint, one bite-sized topic at a time. Today, we're covering a seronegative spondyloarthropathy that's easy to remember, but also easy to miss: reactive arthritis, formerly known as Reiter's syndrome. It's one of those conditions that shows up across multiple systems, and we'll make sure you recognize it when it counts. Let's dive in. Did you know that the classic triad of reactive arthritis, can't see, can't pee, can't climb a tree, only appears in a minority of patients? Most have only one or two of the symptoms, making it a tricky diagnosis if you're not thinking about it. So first, let's look at the Kinderpatho. What is reactive arthritis? Well, reactive arthritis is an inflammatory arthritis that occurs after an infection, including genitourinary infections like Chlamydia or gastrointestinal infections like Salmonella, Shigella, Campylobacter, or Yersinia. It typically presents 1 to 4 weeks after the initial infection and is believed to be caused by an autoimmune reaction triggered by the bacterial antigens. This condition is seronegative, meaning that it is negative for rheumatoid factor and anti-CCP, but often positive for HLA-B27. So, how do these patients present clinically? Well, there are 3 classic symptoms. It's called the classic triad of Reiter's or reactive arthritis. It is conjunctivitis or uveitis, can't see; urethritis or cervicitis, can't pee; and asymmetric oligoarthritis, especially of the knees and ankles, can't climb a tree. So again, can't see, can't pee, can't climb a tree. Additional findings include dactylitis or sausage digits. Make sure to Google that if you don't know what it looks like. Mucocutaneous lesions, typically painless oral ulcers, or circinate balanitis. Another additional finding, which is a real mouthful, is keratoderma blennorrhagicum, which is seen as hyperkeratotic skin lesions on the palms and the soles. Fever and fatigue can also be present in this condition. Remember, symptoms often lag behind the infection, so the initial trigger may be forgotten or underreported by the patient. All right, now let's look at the workup and how to make that diagnosis. So, reactive arthritis is typically a clinical diagnosis, but workups help support it. So, we usually get a urinalysis or a urine NATT for chlamydia. We can get stool cultures if they had recent diarrhea. We also tend to get the typical ESR and CRP, although they can be nonspecific. And we get an HLA-B27, which may be positive, especially in chronic or severe disease. We also get a few things to help us rule out other conditions, like septic arthritis. We want to do a workup, especially if it's monoarticular. We also want to look for gonococcal arthritis and rheumatic fever in young patients. A pro tip is if you see a swollen, painful knee in a young adult with recent diarrhea or an STI, think reactive arthritis. All right, now let's look at the treatment. So the first line treatment for reactive arthritis is going to be NSAIDs, and that is going to help with the pain and the inflammation. Second line, or in persistent disease, we might consider giving DMARDs, including sulfasalazine or methotrexate, and we can consider the TNF inhibitors for refractory or chronic disease. If the patient has active chlamydia, we also want to treat with doxycycline or azithromycin, treat that chlamydia. We want to avoid antibiotics after the arthritis has developed unless there's an ongoing infection. All right, now let's look at the book med versus the street med. So book med, you'll get the textbook triad: conjunctivitis, urethritis, arthritis after a GI or GU infection. Street med, however, you might just see a patient with joint pain and swelling and vague mention of, an upset stomach a few weeks ago, no eye or urinary symptoms, and that's why it is critical to ask about recent infections, even if they have already resolved. All right, let's recap with a few quick clinical pearls. So think post-infectious arthritis, either GI or an STI. Most cases are self-limiting, but can recur or become chronic. NSAIDs are the cornerstone of treatment. Don't forget to ask your patients about diarrhea, dysuria, or eye pain. And I can't help but reiterate the classic triad: can't see, can't pee, can't climb a tree. All right, now let's look at some practice PANCE questions to test our knowledge. Question 1. A 24-year-old male presents with asymmetric knee and ankle swelling. He reports having had diarrhea 3 weeks ago. He also has redness in one eye and mild dysuria. Which of the following is the most likely diagnosis? Is it A, gonococcal arthritis, B, rheumatoid arthritis, C, reactive arthritis, or D, septic arthritis? Well, I don't think I need to give you too much time on this one because it's what we've been covering this last few minutes. So the answer is C, reactive arthritis. As you see in this vignette, we had a recent GI infection, an asymmetric arthritis, conjunctivitis, and urethritis, which equals a classic case. All right, question 2. What is the first line treatment for joint pain in reactive arthritis? Is it A, methotrexate, B, doxycycline, C, NSAIDs, or D, prednisone? I'll give you a few seconds for this one. All right, if you said C, you're right. It is NSAIDs. So NSAIDs are the initial treatment of choice. Doxycycline may be used if chlamydia is still present. All right, some final thoughts. So, reactive arthritis reminds us to always ask about recent infections, even if the patient thinks they're unrelated. It's a diagnosis that connects the dots across systems, and early recognition can make a big difference in preventing chronic symptoms and joint damage. Love all these high yield breakdowns? Follow the ProPA podcast and hit that notification bell so you never miss an episode. For visuals and more clinical content, check out my YouTube channel, Professor GPAC. Thanks for listening to this MSK101 Clinical Medicine Brief on reactive arthritis. As always, this is the ProPA podcast, where future pros in medicine are made. I'll see you later.